So yeah, today we're going to be starting with, we are going to be treating QRS complex. So we've done P wave, we've done redeems, we've done rate, we've done axis, we have treated PR interval. So we're going to be moving to QRS complex and Q wave today. Let me check how many people are in the call so we can just start. Okay, I think I have this is 10 people. Just two people are telling. Is Kiki here? She didn't join last class too. Okay. Freedom.
Ma?
After this class, tell Kiki Dalpe to message me with
Okay, ma.
explanation.
Yes, ma.
Alright.
Thank you, ma.
So we're going to be doing Q wave and QRS complex today. Can everybody see my screen?
Yes, ma.
Can
Yes, ma.
everybody? The females in the class, can you people see my screen?
Yes, ma.
Okay, thank you. So yeah, mm, come- so as for every other waves that we've been treating, the Q wave also has its own depth, or should I say wideness and its height, the width and the height, that it must not be taller than and it must not be wider than. But in Q wave, meaning Q wave, in Q wave, Q wave is the first deflection. I'm sure you're not supposed to be having issues identifying what Q wave is, but if you don't know what Q wave is, which I'm sure you guys know, this is Q wave, this small thing, it is a first negative deflection. Your QRS complex is QRS. Q is the first negative, followed by R, which is the positive, and then S is the negative. By positive, I mean facing up, and by negative, I mean facing down. So your Q wave is the first negative deflection before R wave in your QRS complex, as I said. And what does Q wave represent? It represents initial septal depolarization, which is the activation of the interventricular septum. I told you that QRS complex has to do with what? Your ventricular depolarization, okay? And interventricular septum is just a septum is just like septum is something like kind of divides, right? So the interventricular septum is the septum between two ventricles, usually from the left to the right. But what we really need to know here is okay, so um how do we know that a Q wave is normal? How do we know that it is abnormal? I mean pathological. So yeah, the depth of your Q wave, normal Q wave, is not supposed to be more than two, it's not supposed to be deeper than two small boxes. By depth, I'm coming, I mean like Koyako one do two small boxes law. I don't know if you guys get what I'm trying to say. The depth of your QRS complex or even the height must not be more than two small boxes, and also the wideness, that is the width, must not be more than one small box, that is one small square. So once it is for you to know, okay, your Q wave is pathological, it has to be greater than two small boxes, that is in the height, and then in the width it has to be more than one small box. And another thing you need to know is that there are some leads that if your Q wave appears in them, it is normal. And there are some waves that if your Q wave appears in them, it is abnormal. Okay, now which wave is pathological? Which wave should you not see your Q wave in? Okay, sorry, which lead should you not see your Q wave in? Lead V1, V2, and V3. Anytime you see your Q wave in lead one in V1, V2, V3, it is pathological. It's not supposed to be there. For V4, if it is small, you can ignore it if it's still within the criteria. For
I ask a question.
yeah, you can ask
Are
a
you saying when you said it should not be present in V1 to V3, is it that it should not be present at all, or the depth should not be more than
no,
two small boxes?
it's not supposed to be present at all. But you're
Okay.
going to see your R and the S wave. No, I don't know if you guys remember everything that we have read. There are some lists that you did actually see Q wave in them. So in your V1, V2, V3, you're not supposed to see your Q wave in them. Okay. So now for V4, if it is small, if it's within the range, okay, not wider than one. Sorry, yeah, not wider than one, and it is not taller than two. You can leave it. It is normal. For V5, yes, absolutely. Same thing. It's supposed to appear there and it should not be more than two and then wider than one. For your AVL too, it is normal to see it on AVL. But for your AVF, it's not totally normal, but if you see it on your AVF, it is normal. You see, small for this AVF, small QS may be normal, but large deep ones can be pathological. Now for AVR, you are supposed to ignore any Q wave you see on AVR, okay? Either deep, either small, whatever is happening to your Q wave on your AVL, you are supposed to ignore it. Now, what am I saying in essence? Normal Q waves is supposed to appear in what? In lead 1, lead 2, lead 3, AVL, V5, and V6. And it should be within that range, not wider than two small squares and not wider than one small square and not taller than or deeper than two small squares. It can be tall. I'm just trying to use that depth because most of us are familiar with height. Q wave is negative deflection, so we are talking about depth. So it's that depth that should not be more than two small squares, and then your wideness, your width should not be more than one small square. But what if you see it in V1 to V3? Q wave are not expected in V1 and V2 and V3. So if you see it in this it is pathological. If you see it in AVF you can still leave it, okay? It can be normal, but it has to be small within that range. And if you see it in AVL, you are to ignore it. So which leads are best to assess your Q waves? Like I said earlier, one, two, three, AVL, AVF, V5, V6. Now, another thing is that the clinical correlation of Q wave, everything we have been doing has been having clinical correlation. We talked about the PR interval, which is the heart blocks, and then Wolf Parkinson, White syndrome, and we also we spoke about the P wave, which is P mitral, P pulmonale, the left atrial enlargement, right atrial enlargement. So everything has the Q wave. So it is this way that we will be able to know that, okay, this is what is wrong with our patient by the results that the ECG produced, by the strip, by the waves and the leads and everything. So now Q waves has to do with myocardial infarction. That is the clinical correlation of Q waves. What happens if your Q wave is abnormal? Your patient has myocardial infarction. And myocardial infarction has to do with position, okay? It depends on where you see that abnormality before you say, okay, this is the type of myocardial infarction. Because there's inferior myocardia, there's inferior MI, anterior MI, just myocardial infarction MI, lateral and posterior. Okay, so the inferior MI, just like your inferior leads that view the heart inferiorly. You have lead 2, lead 3, and AVF. You can remember when we were discussing about this lead, I told you about the inferior leads, the anterior, the lateral, and the posterior. And I'm sure you people have forgotten. So for this anterior one, anterior is just basically V1 to V4. And then lateral MI is lead 1, AVL, V5, and V6. And then the posterior is tore out in what? V1 to V2. So basically, this MIs, they're just trying to tell you that, okay, if I see an abnormality in lead 1, let's say it is wider than It's smaller than one small ball. And I say an abnormality in one, in lead one. That abnormality is in lead one. Okay, it is a myocardial infarction, right? But which myocardial infarction? Is it anterior? Is it posterior? Is it lateral? Is it what's that inferior? And another thing you also need to know is that for myocardial infarction you need to look at two leads, even up to three leads. So if I see a lead one, I cannot immediately conclude that okay, the person has lateral myocardial infarction because abnormal Q waves in lead one means lateral myocardial infarction. No, I need to check the other leads that are lateral too. That means if I'm seeing in lead one, I have to check AVL. I have to check V5 and V6. I need to see abnormal Q waves in at least two to three of these leads. Okay, to be able to confirm that okay, yeah, my patient actually has lateral MI. Because some of it might actually be as a result of like maybe the patient was moving, or maybe it should, myocardial infarction is actually a very big case. Okay, so you're not gonna interpret something that is not up to that for your patient, because what might be doing the patient might not be as much as what a myocardial infarction. So now, another
Sorry, my it's actually 10 minutes already.
oh, okay. I'm off to for 10 minutes.